Let's have a look at this patient who's an 80-year-old lady who presented with decreased level of consciousness. A CT scan was done initially, which demonstrated multi-compartment bleed. So the patient was referred for an MR angiogram and venogram without contrast, IV contrast, to pick up any sort of aneurysm or venous sinus thrombosis that could be the etiology for the bleed. So there's some key points to look at in this case. So let's have a look at the axial T2 weighted images. As I scroll from the posterior fossa and come up, clearly there is a bicortical convexity, ongoing subdural hemorrhage. The fluid level is seen on both sides. Clearly there is a rise in the supratentorial pressure, with all the cortical sulci being a bit effaced. There also appears to be some parenchymal foci of bleed in the frontal lobes. A cribriform appearance of bilateral basal ganglia and thalami due to diffuse generalized enlarged perivascular spaces, Virchow-Robin spaces, typically associated with chronic severe small vessel disease, and also associations with vascular dementia, Alzheimer, Parkinsonism, etc. So there are two variants. One would be the cystic smaller variant, where you would see just a diffuse small cystic dilatation. You could have bigger areas of involvement when it would be a lacunar form of presentation. Yeah. Then, of course, there are again T2 signal changes in the pons, some signal changes in the right superior vermis. Let's switch on to the T1 weighted imaging just to see what's happening with the basal ganglia. Clearly you can see the signal intensity of the subdural bleed. Flare images demonstrate the small vessel ischemic changes in the white matter of bilateral frontal lobes, as well as in the basal ganglia. Sulcal signal intensity, high signal intensity, such as component of subarachnoid bleed as well. The Vermian signal is a bit more prominent, probably an ischemic insult. We will cross-check it with our diffusion weighted imaging. Also, the left globe is clearly prominent, as we can see, as some prior insult, and the eyeball is definitely reduced in volume with altered signal intensity of the vitreous and possible lens dysfunction as well. Just so that when you are overwhelmed by findings in the brain and in the extracheal spaces, don't miss out on the periphery of the study. Let's look at the gradient or T2 star sequence. It demonstrates the varying stages of bleed. Some areas are blooming, lentiform nucleus on the left side, bilateral frontal lobes, pons, vermis, cerebellar hemisphere, a little bit along the falx cerebri. So clearly there is a lot of bleed happening without any history of trauma. So we definitely need to look for possible etiologies. Let's look at the time of flight 3D MR angiogram of the brain. So the angiogram is clearly showing that the right vertebral artery V4 segment is hypoplastic and it doesn't terminate into the basilar artery. So the left vertebral artery solely forms the basilar artery. But at the point where we reach the termination of the basilar artery, there appears to be a small outpouching on the basilar top. We'll try to look at it in other planes. The internal carotid arteries do not show any aneurysms. As we go towards its terminal bifurcation into ACA and MCA, again there is no aneurysms. As we go towards the anterior cerebral artery A1 terminal segment and the ACOM, yeah, there is something happening here now. So as you can see here, both the ACAs come together to form the ACOM before they go off as the A2s, and as we come here we can see there is an outpouching over here in isolation. So that's one saccular aneurysm over there. So there should not be, if you're only looking at axial sections, there should not be immediately beyond the origin of the P1 segment of both left and right posterior cerebral arteries. There should be no further protrusion of the basilar artery beyond the termination. So in the sections immediately beyond the origin of bilateral PCA, there is a small saccular aneurysm, basilar top aneurysm. So we have identified two aneurysms already that is present, one at the ACOM and one at the basilar top. The venogram was also requested. We're looking at the sagittal sections beginning from the right side, the superior sagittal, inferior sagittal, right transverse and right sigmoid sinus and the right internal jugular vein all appear intact. So when we start going from the superior sagittal towards the left side, yeah, the left transverse sinus just appears a bit hypoplastic. The transverse the sigmoid is a bit more prominent as it disappears into a generally low caliber left-sided venous system. Otherwise, all the veins, the deep cerebral and internal cerebral veins, cortical veins, and the sinuses are intact. So let's go back to the T2-weighted image. So some of the key learning points in this case is subdural bleed that shows a fluid level, means there is ongoing bleed, sedimentation that's happening, and you can see the blood level. The other thing is the exuberant prominence of perivascular spaces in bibasal ganglia in a cribriform pattern, also seen in bilateral thalami, again a feature of severe small vessel disease. It can be seen in vascular dementia, also in other causes like Alzheimer's and Parkinsonism. And always look for small aneurysms in the angiogram, which could be the etiology for the sort of innocuous intracranial bleeds. And don't forget to look at the periphery of the image for other findings, not probably relevant at this point for the indication, but it's good to document them as well.